Today we're going to discuss aortic stenosis. Aortic stenosis is a valve problem within the heart where the aortic valve doesn't open well. To explain this in more detail, the heart itself is essentially like a house which is made up of 4 rooms. Blood flows from the body back into the first chamber of the heart. When it goes from the first to the second chamber, that valve, which is like a doorway, opens. When it goes from the second to the third chamber, that previous valve closes and the next valve opens. So blood essentially flows in sequence through the different chambers of the heart. The aortic valve is the last valve that separates the heart from the body. In a normal person, when the main pumping chamber, which is the left ventricle, pumps out to the body, the aortic valve opens all the way, and when the chamber's finished pumping, the aortic valve closes. As we age, the aortic valve gets thicker. It's almost like if you look at a regular door, if you have an 80-year-old house and no one's ever cleaned the door hinges, those door hinges get all gunked up with this black stuff. If it gets gunked up enough, you may realize that the door doesn't open all the way. Well, as we age, all of our valves thicken a little bit, and some people it thickens more than other people. But when that valve thickens, it doesn't quite open all the way, and as it opens less and opens less, it becomes more restricted and it's harder for the heart to pump blood out to the body. The most common way for us to figure out if people have aortic stenosis is to put a stethoscope on their chest, because the murmur from aortic stenosis, and all a murmur is a sound that's made by turbulent flow. If a valve opens normally, there's no turbulence of flow. If a valve doesn't open normally, as blood gets pumped out, it creates these eddy currents, just as if you're rowing a canoe on the water, and those eddy currents we can hear, and that's what causes the murmur. But aortic stenosis has a very typical murmur that most physicians would hear with the stethoscope, and if that murmur is significant enough, we usually get an echo, which is also called an ultrasound of the heart, to assess how significant that valve restriction is. An easy way of looking at this is if you want to water your backyard. If you have a hose without one of the squeezy things, you can turn the spigot on full blast, you can hold the hose there, the only thing that's going to happen is you're going to make your feet wet. If you stick your thumb over the end of the hose, the more you obstruct the opening, the farther out the water shoots. The reason it shoots farther is because the velocity of water at the end of the hose is higher the more it's obstructed. So as that opening gets narrower, the velocity of water is faster. And that's exactly what we use to measure the severity of aortic stenosis. As the valve gets more narrow, the velocity of blood going through that aortic valve is higher. In a normal patient, that number is up to 1.7. Between 1.7 and 4.0 is mild to severe, and over 4.0 for a velocity is more than severe. Once the velocity is over 5, that's usually a cutoff for where we say things are critical. Once that velocity is over 5, in the majority of people, the aortic valve needs to be replaced, whether people have symptoms or don't have symptoms. The majority of patients with normal heart muscles in a velocity less than 4 don't have symptoms related to aortic stenosis, and this is something that we follow as it gets closer to a velocity of 4 with an ultrasound every year. If the velocity is 2, perhaps an ultrasound every 2 to 3 years. Once the velocity gets to 4, then we have patients watch out for symptoms and notify us if it happens. If people get shortness of breath or symptoms of congestive heart failure, there's a 50% chance that when those symptoms start, they die within a 2-year period. If they pass out, it's 3 years for a 50% chance of dying. And if they have chest discomfort, or the people say angina, there's a 50% chance of those people dying at 5 years. So usually once patients develop either shortness of breath, passing out or feeling like they're going to pass out, or chest discomfort, and that could be a variety of descriptions of chest discomfort, at that point with the velocity over 4, we usually go ahead and replace the valve. If you are a patient and you've been diagnosed with aortic stenosis, often we're asked the question, what can I do to make this better? Once a valve is restricted, there's nothing that we can do. It's a mechanical problem. Medications won't make that any better. What our goal is to slow the progression of the disease over time. The most common factors that lead to a more rapid progression, most common is smoking. So if you smoke, you have to quit smoking for many reasons, but specifically for aortic stenosis. If your cholesterol is high, there's very good data that being on cholesterol medication slows the progression and either decreases the chances that an aortic valve ever needs to be replaced or lengthens the time to when an aortic valve needs to be replaced. If you're overweight, and especially if you're overweight and have diabetes, getting your weight down is both critical to slow the progression, and also once we replace the valve, we can only put in certain size valves. And if somebody has double the body, it's very hard to get enough blood out of a valve once it is replaced. But if somebody has diabetes, one of the most important things is keeping your diabetes well controlled, whether it's monitoring a hemoglobin A1C, which is an average blood sugar, or time to having glucose within a normal range. Those are the most important things patients can do to slow the progression of the aortic stenosis. If someone does not have critical aortic stenosis, regular exercise is a good thing. It's not a bad thing. So the more someone exercises, whether it's walking, jogging, doing an aerobics class, or swimming, those are actually good things that slow progression of the disease because they also help with blood pressure and cholesterol. And if someone's diabetes, helps to control the blood sugar. As far as replacing the valves, 20 years ago, the only option was surgery, where we would open up the chest, take out the old valve, put in the new valve. Now the majority of aortic valves we can replace without having any cuts on the patient, just through an IV that we put in the groin. Most patients wouldn't prefer surgery and would prefer an IV procedure, but there's specific variables that we need to look at as physicians, such as if there's blockages in the arteries around the heart, if the aorta would be suitable to have it done through an IV. But if you're a patient and you're told the only option to replace an aortic valve is surgery, perhaps at that point it would be reasonable to go to a different institution and ask, is this something that is really only applicable for surgery, or is that the only thing offered at a site? Because not all sites in the United States or the world have the capabilities to replace an aortic valve just through an IV. Thank you for listening to my discussion on aortic stenosis today. If you have any questions, feel free to email me anytime.